healthcare revenue cycle didn't become complex overnight. It evolved layer by layer under pressure from payers, policy, technology, and scale. And today, for many providers, it has quietly become one of the largest sources of financial risk. To understand where revenue cycle is headed, we first need to understand how we got here and what most organizations still struggle to see. Our guest today has spent more than 25 years inside that reality, leading, advising, and stabilizing revenue cycle operation at some of the largest health systems in the country. Please welcome Healthcare Revenue Cycle Executive, Len Mandel. A lot of leaders say revenue cycle has become too complex, but that phrase doesn't actually explain much. When you look back over the past 15 or 20 years, what layers accumulated that made today's environment so fragile?
Sandy, here's the honest answer. Today's revenue cycle environment feels fragile because of 15 to 20 years of layered fixes. So they include regulatory shifts, operational patchwork, but these things have accumulated into something brittle. And none of these layers seem catastrophic on their own, but together they created a system that's incredibly complex, very expensive to run, and vulnerable to disruption. Right? Let me break down a couple of the major layers that's piled up over time. First and foremost, regulatory and compliance accretion. Over the last 2 decades, healthcare organizations have had to absorb a variety of things: HIPAA expansions, meaningful use, MIPS, MACRA, ICD-10 transition, No Surprises Act, price transparency. All these things required a new rule, right? Whether they be new workflows, new documentation steps, new audits, new tech configurations. They're individually manageable, but they're collectively exhausting. And then you have the payer administrative complexity. That's a big deal because payers steadily increase prior authorization requirements, medical necessity rules, denial categories, documentation standards. I could go on and on, right? This is creating a moving target. Revenue cycle teams had to chase this with manual workarounds, appeals, and specialized staff. The result's a system where friction is the default. Then you have technology layering instead of technology replacing. You got bolt-on denial tools, eligibility tools, price estimation tools, CDI tools, charge capture tools, workflow tools, different analytics on top of analytics layers, right? It's just a complexity of issues. Instead of simplification, we get tech sprawl, a stack of overlapping systems that don't talk well to each other, and they require armies of analysts to maintain. But think about all that and having to actually do the job. You've got workforce fragmentation in a lot of places in the revenue cycle, causing over time outsourcing to increase, offshoring increase, vendor specialization increased. Your internal teams shrank, turnover rose, training pipelines were weakened. And the result of this is a revenue cycle that depends on a distributed, inconsistent, and often temporary labor pool, right? That makes it fragile, especially when volumes spike or payer rules change. And then you have the financial pressure and margin compression, right? That's what the whole revenue cycle is about. How do we improve our margin, right? And there's an inordinate amount of financial pressure, right? You have rising labor costs. You have flat or declining reimbursement to contend with, higher bad debt, more deductible plans, more uncompensated care. These things are significant. They force the revenue cycle teams to do more with less. And that often leads to underinvestment in modernization, deferred system upgrades, and reliance on a lot of manual workarounds. Fragility is what happens when you run a system at maximum tension for too long. It's just not sustainable. Another thing comes to mind. We had a shift to consumerism without the infrastructure to support it. Patients became primary payers, more price sensitive, more digitally demanding. You've got these points of contention. But most revenue cycle operations were built for institution-to-institution billing, not retail like financial engagement. But the mismatch created confusion and delays and higher call volumes and more errors. Despite 2 decades of EHR adoption, data still lives in silos. Payers and providers still don't share information seamlessly. Eligibility and benefits data is still unreliable. And prior auth is still fax-driven in many places. Well, this forces revenue cycle teams to operate with incomplete or inconsistent data, which is a recipe for denials and rework.
So each layer solve a local problem, but together they created a system that's hard to see and harder to manage.
Yeah. It's definitely more complex in a lot of ways. There's sometimes misdiagnosis by really smart leaders. It's uncomfortable truth. When these smart healthcare leaders consistently miss, revenue cycle performance rarely degrades because of a single operational failure. It degrades because leaders misunderstand the root cause of the degradation itself. Some of the most common costly misunderstandings across all providers, there's a bunch of things that come to mind, but the leaders assume revenue cycle problems are operational, not organizational, right? The leaders often jump straight to, we need more staff. We need better training. We need a new vendor. We need automation, right? But these things, again, aren't realistic. When you really step back and take a look, revenue cycle degradation is usually a symptom of a deeper organizational issue. You have misaligned incentives between clinical, operational, and financial teams, for one. Sometimes you have poor communication between front end, mid cycle, and back end, and there's a lack of accountability for the upstream errors. I'm sorry to say that, but it's true. Revenue cycle is the receiver of everyone else's mistakes, and sometimes leaders forget that. Sandy, another thing that comes to mind is that the leaders underestimate how much clinical workflow drives financial outcomes. Most revenue cycle failures originate before the revenue cycle team ever touches the account. Whether it's incomplete documentation, incorrect coding inputs, missing prior authorization, clinicians bypassing workflows because they're too complex, they can't do that, right? Just because they're too complex, the clinicians need to ask for additional training. They can't bypass those workflows because they're going to cause issue downstream. Leaders often think revenue cycle needs to fix this, when the real fix is simplifying clinical workflows so the clinicians don't create downstream defects. And then sometimes the leadership misdiagnose technology problems as people problems. When performance slips, leaders often blame staff productivity, accuracy, staff engagement, but the real culprit is frequently fragmented workflows, especially when you're talking about poorly configured rules engines in the system. If you're on automation has to be constantly maintained. Well, you've got some automation that if it's not maintained, things are going to blow up. And you have reporting that hides the real bottlenecks. People get blamed for what the system was designed to break. They don't realize how quickly small defects compound. Revenue cycle degradation is rarely sudden. It's like a slow leak. A 2% increase in registration errors here, a 3-day delay in coding turnaround there, a 5% rise in claim edits, a few denials that don't get appealed. Each one seems minor, but together they create a cascading failure that leaders only notice once cash drops. And by then, the damage is already baked in. You can't fix what you can't see. And that's a big issue right there, right? So, stepping back one more time, sometimes leaders think the degradation is caused by a lack of effort, not a lack of clarity. When performance slips, leaders often push to work harder, work faster, do more with less. But the real issue is usually unclear ownership, conflicting priorities, constant firefighting, no protected time for process improvement. Revenue cycle teams aren't underperforming. They're really overwhelmed. There's a lot of underestimation about how much change fatigue destroys revenue cycle performance. Every year brings new payer rules, new EHR updates, new compliance requirements, new staffing models, new automation tools. The leaders often assume teams can absorb infinite change. That's not sustainable. Other thing coming to mind, leadership believes revenue cycle is a back office function. This is the biggest fallacy. They have to look at it like a strategic function. The biggest misunderstanding of all. Revenue cycle is a clinical quality signal, a patient experience signal, a financial stability signal, a strategic differentiator. When leaders treat it as a cost center instead of a strategic engine, degradation becomes inevitable.
I want to go back on something that you said earlier. You've been on the provider side and the advisory side. When performance slips, why do smart healthcare leaders consistently misunderstand about why revenue cycle degrades?
Things move really fast in revenue cycle. These leaders are looking at metrics. When things slip, it's sometimes not one or two things. It's a trap sometimes leaders fall into when they don't really understand what's deep down in the operation that the hands-on users are having to deal with on a daily basis, right? And that's the problem, right? To get shoulder to shoulder with 100, 200, 300 staff, it's almost impossible to do nowadays.
So why is it such an easy trap for experienced leaders to fall into, in your opinion?
Because things move too quickly, right? Again, you're operating at such a pace because it's a reactive environment instead of a proactive environment. These leaders are putting fires out every day. You ask them to be proactive. It's tough to stop your operation and say, look, we're going to strategize now. We're going to build a plan to transform our operation. Well, if you're going to do that, accounts don't get reviewed, adjustments don't get keyed, things fall behind. So again, you've got this revenue cycle engine that is running on all cylinders. And sometimes, like I said, it's more reactive than we'd like it to be. And that's why it's an easy trap for experienced leaders to fall into, right? They have to manage day to day in a reactive environment. Very tough to do that. Very tough.
So at some point, revenue cycles stopped being a back office optimization issue and became a leadership level risk. When did that shift really happen, and what decisions quietly set it in motion, in your opinion?
The shift didn't happen with a single dramatic moment. It happened the way most business inflection points do. Quietly, then suddenly. Let me break down a couple of things that, sometimes, people don't realize, right? There's more revealing than you think. When revenue cycle became a leadership level risk, you have to think about how it lived in the operational basement for decades, right? Important, but not strategic. The turning point came when three forces converged. Margin compression stopped being cyclical and became structural, right? Rising labor costs, payer denials climbed year after year. Reimbursement growth flattened. At some point, CFOs realized the math no longer worked. Unless revenue cycle performance improved dramatically, that's when it moved from optimize to protect the enterprise. The other thing comes to mind, digital transformation exposed how fragile the underlying processes were. Health systems invested heavily in EHRs and portals and automation and analytics, but those investments illuminated something uncomfortable. Technology can't compensate for broken workflows, Sandy. They can't compensate for outdated policies, and they most certainly can't compensate for siloed teams. I saw this all through my consulting years, right? Teams were siloed. There were no corrective action feedback loops. There were a lack of policies and standard operating procedures between units, back end, front end, mid-cycle. So, with all this going on, the executives suddenly saw revenue cycle not as a cost center, but it was system-wide dependency. Another layer that causes complexity, consumerism changed the cash flow equation. Patients became the fastest growing payer class. And that's something of a challenge, right? You have higher out-of-pocket responsibility, more payment friction, more reputational risk tied to accurate billing. The patient financial experience became a brand issue, not just a back office one. And then the quiet decisions that set the shift in motion. Organizations automated before they modernized. They cut staff before they redesigned processes. They assumed the system would handle it, and it didn't. Other thing that really is an impact, treating denials as an operational nuisance instead of a strategic signal. Denials are a diagnostic tool, but for years they were handled like paperwork cleanup. Now, by the time leaders realized denials are a proxy for organizational health with respect to margin, it's a big deal, right? And then delaying modernization until the financial pressure became acute. That's something else that health systems often wait for a bad audit, a liquidity crunch, a major payer dispute. By then, the revenue cycle is just inefficient. It was too existential. So when did this shift really happen? My mind calls out probably between 2018 and 2022, 4 years, right? That's when the combination of rising denials, workforce shortages, payer complexity, and consumer expectations forced revenue cycle into the C-suite conversation. It became paramount to where we're going to improve the margin, and leadership in the C-suite began to take notice, right? But the real shift happened when leaders recognized this truth. Revenue cycle isn't a back office function. It's a financial circulatory system of the entire organization. That's a big deal, right? And you know what I used to tell my teams? I should say, I'm responsible for the bad debt, right? When I was in industry, my department's responsible for the bad debt of the hospital, but we're not the only ones responsible for the bad debt of the hospital. And that's what needed to take shape. It's the entire organization that's responsible for bad debt. It's the entire organization that's responsible for cash flow.
Let me jump to something else. Over the last decade, organizations invested heavily in technology. You kind of brought that up earlier, sometime a little bit late. Yet many leaders say they have more tools, but less control. Why do you think that is?
Yeah, here's the uncomfortable truth many revenue cycle leaders are finally saying out loud. The last decade wasn't a technology revolution. It was a technology accumulation. And accumulation without orchestration creates chaos, not control. So let me break down Why so many organizations feel like they bought more tools and ended up with less command in a revenue cycle. So more tech turned into less control. Tools were added, they weren't integrated. Automation was deployed tactically, not strategically. Organizations automated steps, not workflows. Vendor sprawl created operational fragmentation. Every new point solution came with its own rule engine, its own reporting, its own support model, its own training requirement. Teams now spent more time managing vendors than managing revenue. The data volume increased, but data intelligence didn't. Organizations collected more data than ever, but it wasn't normalized. It most certainly wasn't connected, and it wasn't made actionable. So leaders have more metrics, but fewer answers. And the technology didn't fix broken processes. It just amplified them. If a workflow is inefficient, automating it just makes the inefficiency happen faster. Many organizations digitize complexity instead of redesigning it. Then you have workforce expectations that change faster than the tools did. RCM teams are smaller, turnover are higher, and the work is more complex. When tools aren't intuitive or unified, staff feel overwhelmed, not empowered. And then here comes AI, right? But in disconnected pockets. Everyone bought AI. Everybody says, oh, AI is the new shiny penny. But each tool uses its own model. Each model makes decisions in isolation. No one sees the full patient financial journey. So leaders can't govern or trust the outcomes. But the core issue is that technology outpaced governance. That's a big deal, right? Organizations bought tools faster than they built the operating model to manage that. So the result is more tech, more noise, more exceptions, more manual work, and thus less control.
So technology did not reduce complexity. It just fragmented accountability. Would you agree?
That's right.
So where does that loss of control show up first?
The invisible backlog starts to grow, not as a dramatic spike. It's just a slow, steady accumulation of things, right? With this, organizations of every size and flavor, the same early warning signs show up long before revenue cycle metrics actually fail, right? It's a breakdown in operational rhythm. It's subtle at first, but then it becomes remarkably consistent, right? So when the backlog starts to grow, people start looking at the discharge not final bill creeping up a few points, the coding queues taking a little longer to clear, claim edits lingering an extra day, prior auth sitting untouched for a bit longer, right? That's a problem. Leaders often don't notice it because the numbers still look fine, but the velocity of work has changed, and that's significant. All throughout my career, Sandy, the cross-functional communication has been siloed. Right now it's choppy. They're getting better, but you still see small fractures between clinical ops, coding, and billing, right? With fewer huddles, more email chains instead of real-time problem solving, delays in clarifying documentation, arising, we'll get to it tomorrow, right? Because of the fires that they're putting out. And this is usually cultural, not technical, right? We have to build back in corrective action feedback loops. We have to build back in cross-functional teams, whether they be for unbilled, whether they be for denials, whether they be for AR. It doesn't matter. Those cross-functional teams are stronger together because the communication gets strengthened, right? So that's a big deal. The next comes to mind, you have the staffing stability, right? It's a wobble, right? It fluctuates, just enough churn or absenteeism to disrupt the flow. It's not mass turnover, right? You have a few experienced coders that leave. A registrar's out for a couple weeks. A new hire isn't fully trained, but they throw them in production, right? The systems absorbs it until it doesn't. And that's where the leaders shift attention to other places, right? This is the most universal precursor. When leadership focuses on other things, whether it's a new HR module or service line expansion or a merger or what have you, the revenue cycle loses its air cover. Performance doesn't drop immediately, but the guardrails weaken. And then you have quality signals that are degrading before the financial ones. You'll see more documentation queries, more coding errors, more registration mistakes, more denials for preventable reasons. These are the canaries in the coal mine. So the underlying pattern, revenue cycle performance slips when the system's cadence breaks, before the numbers do. It's always a workflow slowdown, a communication drift, or a leadership distraction that shows up first.
So across different health systems, large, small, academic, community, what pattern do you see repeating right before revenue cycle performance starts to slip?
When you talk about a pattern, there's a variety of things, right? Again, you've got frontline pain showing up as more rework, more denials. I'm not sure who owns this. More time spent chasing information instead of completing tasks. Finance feels it later, but louder, right? Typically, you're detecting the issue only once it becomes measurable. whether they're rising AR days or the denial rates creep up, or cash is volatile, or you have lagging charge capture, or it takes too long to close the month. By the time finance sees the metrics shift, behavioral issues have already been happening for weeks or months. And you know what? This really matters, Sandy. If you start with the metrics, you're diagnosing symptoms. If you start with behavior, you're diagnosing causes. The smartest revenue cycle leaders treat frontline behavior as an early warning system, a kind of quality leading indicator that predicts the quantitative lagging indicators finance eventually reports, right? That's a big focus change. And that's something, again, I'm seeing it become more prevalent in the industry, but it's still in some ways slow to adopt, not because it's intentional, but because the revenue cycle leadership team is still constantly reactive. They're putting fires out every day. They're managing more with less, and it just becomes a cycle.
So the breakdown doesn't start with metrics. It starts with behavior. Who usually feel that first, finance or frontline teams?
It's going to be varied. When you realize that behavior is an issue and where it's coming from, almost everyone who spent time in the revenue cycle has that moment, right? It's the point where you realize the problem isn't the claim scrubber or the EHR or the clearinghouse or the payer portal. It's the humans, the habits, the handoffs, and the unspoken norms that shape how work actually gets done, right? So it's not like, an immediate realization, right? The realization usually hits people the moment the illusion breaks. And what I mean by that is for many leaders, the turning point comes when they see a team with the same technology, same workflows, same policies produce wildly different outcomes. You walk into two clinics, for example, they're using the same system build. One has clean registration, low denials, and predictable cash. The other's drowning in rework, missing authorizations, and constantly fixing it later. Type cycles, right? Nothing technical changed. The behavior did. That's when it clicks. Revenue cycle performance is a human system disguised as a technical one. You want to see those specifics? We have to look again to operational intelligence, right? Because why did those two clinics have the same system build? One's got clean registration, the other one's drowning in rework. That's where operational intelligence will tell you what the difference is. And that's something, again, we need yesterday. So very important. And then what usually triggers that realization? You asked me that a few minutes ago. People often describe moments like shouting a registrar and realizing they've invented their own workflow because the official one doesn't work in real life. Well, what does that mean, right? And how do I validate that, right? Same thing. You're watching coders interpret documentation differently depending on who trained them. You see a spike in denials, right? What does that mean? You have to trace it back to one person who misunderstood a payer rule. Noticing that two supervisors enforce the same policy with totally different outcomes and totally different expectations. And then, one of the things that drove me nuts over the years, you hear frontline staff say, we've always done it this way, even when the system was updated months ago. It's humbling because it shows that the dashboards don't run the revenue cycle. People do. So why does this matter for leaders, right? Once you see the behavioral layer, you stop trying to fix everything with more audits, more reports, more technology, more policies. And then you start focused on clarity, right? You got to focus on the clarity, the consistency, the coaching, the accountability, the communication, and the culture. That's where the real leverage is. And that's why you keep hearing me talk about, the operational intelligence, right? We have to focus on the humans, right? And what we're doing to understand clarity and consistency.
If a CFO or VP of revenue cycle is listening right now, Len, what's the first assumption about the operation they should challenge?
Yeah, it's a good question, Sandy. Our problems are caused by broken processes or technology right there. That assumption feels logical, even responsible, but it's almost always wrong. The real friction usually lives one layer deeper. Here's the more accurate version of that, right? Our problems are caused by how people behave inside the process. And once a leader challenges that assumption, the entire lens shifts. So why is this assumption so dangerous? Executives often believe we need a new workflow. We need better automation. We need more reporting. We need a system fix. But these structural solutions to behavioral problems, that's not going to work, right? Because that's exactly what they are. They're structural solutions to behavioral problems. You can have the right workflow. You can have the right policy, the right system build, the right metrics, and still get the wrong outcomes if the daily behaviors don't match the design. And that's where, again, leadership discovers when they're challenging the assumption, right? They're finding that the variation, not the process, is the real enemy. Workarounds quietly rewrite the workflow, right? We can't have that going on because people don't follow the documented process. They follow the survivable one. Accountability is uneven. That's a problem. Some supervisors reinforce expectations, others let things slide. Now, and then you find that there's inconsistent communication, the payer updates, the documentation changes, the staffing issues don't cascade cleanly. Training's episodic. It's not continuous. That's another problem. People learn once and then people learn once and then they improvise forever. None of these show up in the policy manual, Sandy. All of them show up in the cash flow. So you know what, in conclusion, the leaders who get ahead, they have to ask a different question. Instead of what's wrong with that process, they should ask what behaviors are happening in the process that we didn't anticipate, because that's where the truth lives.
Oh, this is good. We're going to unpack that in our next episode together. Before we end this session, I know off camera, you and I were talking that people don't just accidentally become expert in revenue cycle at a large provider. So tell me a little bit more about the young who are listening out there, new business graduates who wants to look into a career or building something, and they have a degree maybe in finance or accounting. What guidance do you have for them? How do they enter that field? How could they learn about this process?
That's a good question, Sandy. When I was doing recruiting down on campus, I had these similar conversations, right? I'm talking to really smart graduates, right? They're just about to graduate and go into life with really terrific degrees in finance and accounting and such. So the main thing is, what do you like best about business, right? What type of business do you like, right? Have you ever considered healthcare as a business, right? Not the clinical side, but the financial side. Those are the probing questions, right? And some of the folks said, yeah, again, my mom's a nurse or my dad's a doctor, and I've thought about healthcare finance. The majority haven't. And that's where, you have to kind of lead them on and say, all right, you like accounting, right? Have you ever thought of patient accounting and what that means? They say, oh no, what does it mean? I said, well, you take, the university health system, you just graduated from the university, their health system has got $2-3 billion in revenue. That's pretty significant, wouldn't you say? They say, yeah, it is. I'm like, well, how do you think people track that accounting? Well, what do you think that has to happen every month for month end and everything that goes into it with revenue capture? Then they start getting curious. And then you start elaborating a little bit more about what does that mean, right? When you're talking about patient accounting, you're talking about patient service revenue. And that's significant, right? So the folks that have strong business acumen, all of a sudden a light bulb goes on in their head. And they start seeing that as an opportunity for a career in healthcare finance, in healthcare revenue cycle, and patient accounting, right? Because you still have the general ledger, you still have the income statement, you still have the balance sheet, you're still managing accounts receivable. It's all finance driven, right? But the complexity of it's dynamic, right? So I kind of put that into play as far as the dynamic environment. But more importantly, Sandy, it's more of a desire that you want to help people, right? Health systems keep patients alive. So if you're in healthcare finance, especially in a revenue cycle, you're responsible for the cash flow of the health system. Well, the cash flow of the health system improves patient care. So a lot of folks, they find that very fulfilling when they start considering it that way. And that's how some of these folks are now getting into healthcare finance, healthcare revenue cycle. Several of them started in the consulting world, right? They come right out of college. They're recruited by the Big Four. That's when I was down on campus, right? So these folks would come into our firm as a first year. They might even come in as an intern. And then they're assigned to projects and they see what it is, right? They see the analytics. They see everything that drives cash flow, right? Where's the revenue? Who's accounting for the revenue on a daily basis? How do the bills get configured? How do we respond to denials? It's a whole cycle. So they get exposure that way from the consulting angle of it. They're given various projects. And then folks that if they want to continue on consulting, they usually get really good at operations and they, go up to the partner chain. Others, they'll get to a certain point of managing projects and then they drop out and they go into the provider space. They can manage their own projects from the provider level. So again, you've got a couple different entry points, but it has to be properly explained, to the new graduates as far as what does it mean and how is it significant? More importantly, how fulfilling is it for you as a finance executive? And then I bring back the idea again of patient care. That's the main thing, right? That's the type of business it is. It's fully driven. The cash flow has to keep patients alive. And they find that very gratifying. They find that very fulfilling. And they decide, this is the industry that I want to be in. Simple as that.
Very cool, Len. Thank you very much for your insight. This was super helpful. We'll catch you on the next episode.
All right. Sounds great.